Dr. David Ansell is Senior Vice President for Clinical Affairs and Chief Medical Officer, Associate Dean for Clinical Affairs, and the Michael E. Kelly, MD, Presidential Professor at Rush University Medical Center in Chicago. Prior to coming to Rush in 2005, he was the Chief of Internal Medicine at the Sinai Health System in Chicago from 1995 to 2005, and Executive Vice Chairman of the Department of Internal Medicine at the Chicago Medical School. At Sinai, he was responsible for the establishment of the Sinai Urban Health Institute, a leading health disparity research and intervention center. Dr. Ansell did his undergraduate work at Franklin and Marshall College and graduated in 1974. He received his medical degree from the State University of New York Upstate Medical Center at Syracuse in 1978. He trained in internal medicine at Cook County Hospital from 1978 to 1982 and served as an attending physician there until 1995, holding a number of positions, including Division Chief of General Internal Medicine and Primary Care. And if you've read his book, you know he had a few side jobs too. He was the founder of the breast and cervical screening program at Cook County Hospital in 1983. He has a master's degree in epidemiology from the University of Illinois School of Public Health. Dr. Ansell is board chair of the Metropolitan Chicago Breast Cancer Task Force, a not-for-profit agency that is looking at metropolitan Chicago interventions to improve the quality of breast care and reduce breast cancer mortality disparity in the region. He's the former director of the Cook County Health and Hospital System. He's a member of the Association of American Medical Colleges, Integrating Quality Steering Committee. His research interests are access to health care, health disparity reduction, quality and patient safety, and he's lectured and written widely on these topics. He wrote a book called County. It received critical acclaim in the New York Times, Chicago Tribune, National Public Radio's Fresh Air program, and was recognized by the Wall Street Journal as one of the top 5 books on health in 2011. He's lectured across the country, and luckily for us, he's agreed to come and lecture to us today. So we're more than glad to have him, and David, the podium is yours.
Thank you, Bob and Chad, Teresa, and the Ogden Surgical and Medical Society. My wife is here, so I have to be a little bit careful of what I say today, but is there a slide advancer here? This is it. I see. So this is actually a beautiful picture of the hospital I trained in. I know a couple people here trained at Cook County Hospital. Raise your hands. Oh, good. Okay. So I'm David Ansell. That's me standing in front of the county hospital. I have no disclosures except to say the following. You're going to hear today a little bit about my experience. I promise to be controversial, and I look forward to your questions. I guess I'm disclosing that in advance. But through this talk's evolved over time because, I wrote a book. Doesn't matter what you do, but you write a book, and now people ask you to come talk. But this talk has 3 parts. Part 1 is 3 hospitals, 1 street, 2 worlds. My past 35 years in Chicago. Part 2, you get to be part of a poll. Now, it's a little bit high tech. Who has a cell phone here? Raise your hand if you have a cell phone. All right, that's enough for you. Not everyone has to be in it. But this is Chicago, so you can vote more than once. So raise your hand if you know how to text message on a cell phone. All right, This poll is done electronically through text messages. And and it's not too long, but you get to be part of a poll because I want to get your opinions on some questions about healthcare in this country. And then 3, you're going to get my opinions about the achieving the triple aim of healthcare, what I call the promise of real health reform. So it was said I'm Chief Medical Officer now at Rush University Medical Center. It's an academic medical center just west of the Loop in Chicago, and that's our new $700 million building. Very expensive. But a little bit about me. So, you know, you get less cute as you get older. Everyone's cute when they're young, but my parents were immigrants to this country. They were in England. My father was actually started off as a GP in a small town in a converted gas station, and he was actually president of our local medical society in our town. But my mother's family, my parents were from England, my mother's family was from Poland, and they would go back every summer, and her whole family got wiped out in the Holocaust. And as a child, I wondered, the question, and growing up in the aftermath of this, it wasn't that governments can do bad things to people, but what about the neighbors? You know, I really thought about the neighbors and saying, well, how did they react? And why did they react? And why didn't they speak up? And I think reflecting on that as a child made me feel as if I needed to speak up when I was in situations. And you'll see how that evolved over time. But the other thing about being a child of an immigrant or a first-generation American, this is a great country. We have great beliefs and values. Freedom, liberty, all of these great ideas. And I was, I think, infused with the optimism that immigrant first generation often have about our country, and still feel that way. So now I'm getting to part 1. Now the good thing about doing a talk in 3 parts, if you don't like the first part, the next part's coming soon. So, but for anyone who's been in Chicago, a diagonal street in Chicago is an old Indian path. And Ogden Avenue goes from the Lake Michigan across Chicago. And I have worked in 3 hospitals within a mile of each other on that one street in Chicago. It was an Indian path. It was a shortcut to New Orleans. So if you were a French voyager, you went up through Minnesota to the Mississippi River. And if you're an Indian, you shortcut through Chicago and got to the Des Plaines River, to the Illinois River, to the Mississippi. And Ogden Avenue became a plank road when it got too muddy and finally paved over. And it was Route 66, the major east-west road across the United States. But it just so happens that the 3 hospitals I've worked in and my patients have followed me to are within a mile of each other on one street. And you can't design a crazier healthcare system than you can find in these 3 hospitals within a mile of each other. And I like to tell the story about my experiences as a primary care physician. So I was 17 years at Cook County Hospital. You'll hear a little bit more about that. I went from being intern to chief of general internal medicine. Of all the primary care internists, I was it. And in those 17 years, how many of my patients who needed it do you think got a joint replacement? And I'll take a guess from the audience here. Exactly 0. Exactly 0. Because you couldn't. In fact, today, there's a 5-year waiting list at Cook County Hospital, across the street from my hospital, to get a joint replacement. Now I'm at Mount Sinai, the trauma center. I'm the chief of internal medicine. And at Mount Sinai, 2. But I'm at Rush now. Now, Rush is the #1 ortho program in the Midwest. And you limp inside the front door at Rush. And in a couple weeks, you can get your joint replaced. And it's on one street. And so the chief medical officer at the county hospital, and I we have a beautiful dining room at Rush, and you can really see the county hospital out the window. And this is when I sat on the board of the county hospital a couple years ago, and he said to me, "David, the waiting list for the eye clinic is so long at Cook County that you can go blind on the waiting list. Whereas in my hospital, if you come in across the street, you can see the eye, an ophthalmologist, within the week. And so my patients of eye have experienced this inequality on one street in Chicago in a way that you can't believe. So that's, but I wrote this book, County, after coming to Rush, because I don't think I really understood how profound these gaps are until you've lived it. Because it's not the doctors or the nurses, actually, it's the system. It's the system that we're in that's evolved over these many years. It's not us, because I'm the same doctor, and it's actually the system you're embedded in. So 35 years ago, I was a medical student. I'm this hairy one in the middle there. But I was a medical student. I didn't particularly like medical school that much, and part of it was I knew I wanted to be a doctor. I knew that's what I wanted to be, but I wasn't so sure why I was there. The curriculum was lacking in many ways, it seemed to me. I was not enthused about being there. In fact, in the first year I was married to my wife, my wife has told me I can't point her out in the audience. You can see her in the picture here, and now you're going to have to figure out who she is in the audience, because I cannot draw any attention to her. I'm under strict orders. But I was so disillusioned with medical school, and being in Syracuse had a forestry school, that I liked the outdoors, and I said, I'm going to be a forest ranger, and I got an application to quit careers and be a forest ranger. But a group of medical students and I got together, and we sort of studied the U.S. healthcare system. What is this all about? And I realized that I knew I wanted to be a doctor, but I didn't really know why, and I figured that out for myself. And we just decided that, to be a doctor, to help people, that we believe that healthcare was a human right. Now, I put this out there because this is not why in this country, the idea that healthcare is a human right has not been resolved. This is a non-resolved issue in our country. I think it's one of the moral issues of our time, just like women's right to vote, or slavery, or other forms of discrimination were out there. I think this is an idea that's been resolved in many other countries, but not in this country. And I think the failure to resolve this moral issue is at the root of many of our crazy deliberations about health care. That led me to go to Cook County Hospital, because I decided, and my friends decided, that we wanted to train in a place where the idea that health care was a human right was out there in front of you. So we didn't want to be involved with, we said, let's just go to a place where we just take care of people, regardless of ability to pay. We get to learn to be doctors. We traveled out to go to Cook County Hospital on this interview. We set up in advance to meet the chairman of medicine. We all hopped in a car, drove from Syracuse, 800 miles, past the smokestacks of Gary, Indiana. And we show up at Cook County Hospital. You open the door. All your ideals that you have in your head are challenged when you walk into a public hospital or a public clinic or something. We walked in that door, and it was one of the scariest moments in my life. I was an Eagle Scout, and yet I don't think I'd experienced the kind of environment that I experienced when you walked into Cook County Hospital. We went up to meet with the chair of medicine, go to his office, and we say, we're here to meet with Dr. Young, and they say, he's out of town. I said, how could he be out of town? It's not on the appointment list. So here we are, stranded. We get whisked off to a meeting in a room like this. Someone sits us down. They shove a leaflet in our hand, and it says Cook County Hospital closing. And people are up on the stage, and they're saying the hospital's going to close. If it doesn't get money, it's going to be closed in July. And a family medicine resident, he's chief of family medicine now at Kansas, reached over and said, are you guys here to interview? He said, yeah. He said, oh, you got to come here. It's great. So we interviewed, sort of an interview, and we decided we were going to go there. And we went back to medical school, and our professors thought it was career suicide, because while County had been one of the great training places in the country and a great teaching institution, by now academic medical centers had taken over as the places to go, and there was a number of reasons why they warned us about going there. But though it was once one of the greatest teaching hospitals in the country. In fact, at one point, one out of every 3 doctors in the country spent some time at Cook County Hospital. The Mayo brothers trained there, for example. That's where they got their surgical training. It was one of the best in the United States, but it was always troubled. This is, on the left here in the middle is Christian Fenger, who was a surgeon and a pathologist. And at a time in the late 1800s at County Hospital, the expenses for liquor were greater than the surgical supplies, and so they were rationing surgical supplies. And he had a patient who had a ruptured viscus, and he repaired it. And then the patient died subsequently of peritonitis. And he's doing the autopsy, and he pulls out a piece of catgut that was rotten. It was a rotten piece of supply. And he shook his hand in the direction of the administration building, and he shouted, "Reformers no, murderers." I say this because we were there a century later and experienced some of the same conditions. But it was a great teaching place. On the left here is Herrick. This is James Herrick, a Rush professor. The only reason people want to be Rush professors was to be at County Hospital. He was discovered coronary artery disease, described sickle cell anemia for the first time. And it was just a wonderful place to train, as it was in my time. But by 1978, it was not the place that American medical students went. They maybe spent some rotations there. It was at the crossroads of really everything that was challenged in our healthcare system, some of which we're living through today here. It was run down, threatened with closure. And what had happened in Chicago was a number of different things. Between 1930 and 1960, the black population of Chicago went from 250,000 to 1 million, invited in for jobs. So a little bit of U.S. history. It was European immigration supplied a great number of the workers in this country, and it was shut off in the 1920s. And then you got the pre-war and the post-war years, and we now required workers to work in our factories and such, and we had to turn to internal labor, and it was minorities, and it was blacks and Mexicans and others who were asked to come to the cities, but the cities were not ready for this influx of people. And it turns out that by the early 1960s in Chicago, a study was done that said 50% of all black deaths and 80% of all black births were at Cook County Hospital, which is kind of amazing. Cook County Hospital in a private black hospital called Provident. In fact, when I got to Rush, I had a walk-in patient, and the first time I ever had a patient who had a birthday the same day as mine. And I said, "Oh, you and I are the exact same birthday, same year." And he looked at me and said, black guy, said, "Oh, were you born at Cook County Hospital?" And he said that because everybody in a certain generation was born at Cook County Hospital. So when it came time to match Cook County Hospital, we decided we just put one place on our match list. So we all knew where we were going, and we all matched a county, and that's where we ended up going. 2 years before we went there, the doctors had gone on strike, the house staff, over the most basic of patient care conditions. And I like to point out this guy in the middle is Jack Raba. Jack was 26 or 27. He had been a seminarian. He was not a political bone in his body then or now. He was just a decent guy. And this was things for like soap and water and EKG machines, common things that you would think you should be able to have in a hospital. And, realized we had landed a man on the moon in 1968, and this was in one of the biggest cities in the country, and they were really deplorable patient care conditions. Now, for those of you who've trained there in the past or other hospitals, this is no different than anywhere else in the United States. It's just what happened is things that were tolerated became noticed and became more intolerable. The other thing that happened was across the country, public hospitals were closing. So Philadelphia General had closed and others had closed because these were places of patronage and there wasn't that much interest in improving patient care conditions. The other thing that happened in the cities is that people were relatively well insured. These were the days of actually pretty good insurance. So people might have been turned down in those days because they were undesirable because of race, But there was great insurance in the cities in this country because all the cities had factories in them. And these factories had jobs for life and insurance. And then in this period of time, the other thing that happened is these factories began to close down, moving first to suburbs, then west and south, and now to China. And we saw the beginning of the rise of the uninsured. What happened was this is them marching downtown in defiance of the back to work order. This is, to this day, the longest doctor strike in U.S. history. And they weren't striking for money, they were striking for patient conditions. They won the strike, and then Jack and 7 of the other strike leaders were thrown into Cook County Jail for 10 days. And Jack tells a story. So Jack tells a story, he's in Cook County Jail, and they need people in the jail infirmary. And so they let him out of his cell, and he goes and he works on patients, and they take care of the backlog. And by mistake, he walks out of Cook County Jail. And he realized he's supposed to be in the jail, so he has to knock on the door and get back in. When I was a house staff, this was one of our rotations. We'd do rotations at Cook County Jail, and the conditions were kind of bad. We said, we're not going to do it anymore. And they decided to professionalize correctional medicine staff, and they decided to hire a medical director, and who do you think they hired? Jack Raba. And you can say this about Jack, he knew the place inside and out. And he's actually a national leader in correctional medicine. A lot of the stuff that happened, the group of people who joined that became national leaders in correctional medicine and such. But that would seem to be a deterrent to going to this place. And we thought, well, listen, there are a bunch of young doctors there. They seem pretty excited about it. The goal was, twofold: keep the place open and learn medicine. And we weren't sure of either part of that, of whether we would. So on one hand, county is a coming-of-age story. I remember when I got when my internal medicine boards came in, after spending 4 years and training there, I had no idea what I knew compared to anyone else. And my wife, Paula, who I won't point out, brought the envelope, and I said, open it up and read it. And I passed the boards. I said, oh, I must have learned something. But it was the context. So one is a coming-of-age story that we all went through as doctors and training and nurse practitioners. I describe, looking back on it, is kind of absurd. I call this doctors within borders, because we would see patients, and then we would go to do something to try to keep the hospital open. And there's a couple things here. This is when my current hospital shut down a street that was the ambulance route to county. So when Presbyterian Hospital bought the street for $1, and it was the major ambulance route for county, and there was a demonstration to try to keep them open. But but part of what we did was to try to, how do you keep this place open? This is actually, one day it happened. There was no pay. No one got a paycheck, and we thought this was it, and this is how it would happen in other cities. And so there was a spontaneous, at noon, people got together and said, well, what are we going to do? And someone says, well, let's take the patients over to Presbyterian, which is right across the street, my hospital now, Rush. And so this is from the Chicago Tribune, people pushing patients over in wheelchairs, something that I don't recommend doing. But my CEO, so the book came out, and my CEO was the first one who got a copy of it, because I said, okay, I'm writing about some of the things that happened. And it turns out he was chief resident in internal medicine the day this happened, when we pushed the patients over to county. And I'm having this conversation with him. He said, we thought, what are you guys, nuts? What are you doing to these patients? And I said, yeah, it was kind of stupid. But you have to understand how we felt as well. But that was the world on one street. These two worlds. And I talk about that in the book. But really what struck me the most of all of this is the patients and the conditions. And this is the general medicine clinic waiting area. And that you think of a county hospital as the guns club and the knife club and such. And it really was just about people who needed care, people who needed the most basic of care, who were very grateful for the care we did. They thought we were the best doctors. But how could we have been the best doctors? There's no way we could have been the best doctor. But they looked at us as if we were the best doctors. And so I think as a young physicians, we really felt compelled to learn medicine as well as we could. And I think some of the lessons that, from training there have carried me where I am now. The fact that I'm chief medical officer of a major academic institution has everything to do with those decisions. You think about what makes a life for any one of us. So we're going along, and then you make a decision. And after you make that decision, there's a major change in your life that you look back and you see these sentinel moments. There are not that many of them. For me, it was when I met my wife. Now, that was sentinel. For her, it was like triple sentinel. But that was it. But going to county was one of those things. I mean, it really made me who I was as a doctor. And the patients, when you took it all aside, and what really was there was patience and being a doctor in the most pure way between you and a patient, and you did everything you could to try to save that life or improve things. And I talk about that. I think maybe the best part of this book is when I talk about my patients, because that's the connection I have. So I told you my parents were English. The BBC in 1979 decided to come to America, and they wanted to show the Brits what healthcare in America was like. So they came to Cook County Hospital. And I didn't know about this till after the book had come out, and I found the producer of this BBC documentary. But my relatives saw it on TV and were calling my mother to see, is David okay? So remember this, I told you about Christian Fenger in 1876, reformers know murderers. This is what the BBC called the documentary. I call it murder, 100 years later. And the reason they said this was they interviewed a doctor, a member of the House staff, Dr. Linda Murray, was president of the House Staff Association. They were bringing these patients into Cook County Hospital, rolling them in one after another. And they're standing there in the ER, and she said, they asked to her, this young doctor, would you describe to the British, what's going on here? And she said, well, I call it murder. And that became the name of the documentary. And this is a clip from the documentary. So, listen, it wasn't enough just to have ideals and say, because of my ideals, because I believe healthcare is a human right, I'm going to Cook County. It's not enough. Do you know what I mean? And it wasn't enough just to walk in the door with ideals and say, okay, we're going to try to keep the hospital open. You had to become a really good doctor, because who are you if you're not good at what you do? But the third thing that came up is it was kind of the fix-it mentality. We believed that we could make it better. We really believed we could make it better. We were, looking back on it, there was a bunch of young, brash, and we were optimistic about it. We believed that if we could really turn around. So I'm going to tell you about one problem that we took on, among many. So this is from the Sun-Times, and you can see what it is. It's a dump truck, Cook County Hospital emergency room, dumping patients at Cook County. So, the methodology that many of you learned, see one, do one, teach one. You went to the emergency room, and you stood there, and there was other residents around. In those days, no attendings. That was standard practice in the U.S. And the phone would ring, and you'd go and you'd answer the phone, and it'd be another hospital. You said, hello, and they say, this is University of Chicago Hospital. We'd like to transfer you a patient. Next to the phone was a clipboard. On the clipboard was a piece of paper or a pen tied to it, because pens would get stolen there easily. The name of the patient, date of birth, diagnosis, and then a bunch of check boxes. And you just filled it out. And reason for transfer was one of them. And what do you think the reason for transfer almost always was? No insurance. But we just did it. There was no. Now, I always try to, this is the thought about this. So you're the resident on one side, and there's a resident on another side. So we're all similar. We're all trained the same way. We all came from, nice families, nice towns. We go to church, synagogue, mosques. We do all that stuff. Now you're put in this situation. So I picked up the phone, and there's some kid on the other side of the phone sending me the patient. And we just did it. That's what you did. No question about it. But what happened in the early 80s, because of the rise in the uninsured, so I wanted to remember 1980, the number of uninsured in this country was about 25 million. 25 million. And what happened is hospitals finding themselves unable to care for the rising uninsured in their midst began to then, in urban areas and probably in rural areas, to transfer the patients to the county hospitals. What's happened, always happened, but what changed in the 1980s was the numbers. Cook County, it went from 100 a month to 600 a month. And this is how I got to be a professor in medicine in a way. I never thought about doing any research. I had zero interest in research. But we said we should do something about this. A group of residents got together, young attendees, and we said, well, no one's going to listen to a bunch of county docs who complain about patients being sent to them for no insurance. So we said, why don't we do a study? None of us had ever done a study. But we said, why don't we just track 500 consecutive patients who go to the emergency room of Cook County Hospital. That was 3 weeks. So we went and we collected every ER sheet of a patient transferred. We went and interviewed every patient, and we wanted to get the say about informed consent. So what did they tell you at the other hospital? And then we looked at what happened. So we went and asked and said, so think about the young resident on the other side of the phone there who's been told by his hospital that you can't take this patient because they're uninsured or the attending won't come in. And what do you tell the patient? So what do you think the patients were told the reason for transfer was? No beds. So the patients, we were told no insurance, they were told no beds. And it turned out we tracked what happened to them. About 25% were unstable at the time of transfer. Another about 25% ended up in an intensive care unit. And the medical patients had a higher mortality than the directly admitted medical patients. When people found out that we were doing the study at county, there was a bit of controversy. In fact, even in our own group, there was controversy about what do you call this and such. And people were upset because there was a group of people who said, well, this is what county hospitals are for. There are places for the poor people. And this is what they're for. They've been here since the beginning of time, and that's the way it should be. And we said, yes, if someone shows up at our door, we have to take them. But if they show up sick in an emergency condition at another institution, shouldn't they have to take them in? And it was a big debate. In fact, it was such a big deal that we wrote a paper, and we sent it in, and it was about to be released. And we asked the hospital if they would help us, the one press guy, if he would help us with a press conference. He said, no, I can't help you. The hospital's been told we can't help you. So the four of us got up and we read a little statement in a room. In the room next door to us, the hospital held a counter press conference. The chairman of the Cook County Board called us a bunch of amateur sociologists. Anyway. So we didn't know, where do you send a paper into? We had never done this before, so we sent it in to the only place we knew, the New England Journal of Medicine. It got published, and the next day it was on the front page of the Chicago Tribune, New York Times, Wall Street Journal. I got invited to come on Nightline, and the lead author, Bob Schiff, Oprah. And man, he's a lucky guy. But I went to testify, we got called to testify before Congress, in which we said, you know, that we tell the story. I'd like to say a picture's worth 1,000 words. Now think about you're being the doctor on the other side of the line, sending patients to the hospital because that's the rule, and we're all cogs in the system here. So we did in this paper a table in which we randomly selected patients from these 500 who were transferred, actually 467, and we just described their clinical scenarios. So I'm going to give you two. Gunshot to the head, on a ventilator, transfer to county, reason for transfer, no insurance. Or this one that really sticks to me after all these years, woman in terminal labor, 10 centimeters dilated, breech delivery, foot in the vagina, transfer to county, no insurance. And our OBs, after the study was published and federal law was trained, the Emergency Medical Treatment and Labor Act was passed, as a result of this, that makes it against the law to do this for patients in emergency condition and actually got us presumptive Medicaid eligibility for women who are pregnant. Our OBs thanked us because of women who died in our emergency room in labor, giving birth. And I know Dr. Evans, who called me up when who trained at County, would tell me about walking through the ER at County and having to look at women who had ruptured ectopics, who they had to pick by looking at them out of the audience in a way to do it. So this was the just fix it mentality that we had. So afterwards, I stayed on at County. I said, I got to do something to do prevention and early detection. Just taking care of end-stage disease is not going to, and I started a breast cancer screening program. Again, I stayed on for 17 years. So we won the fight for a new hospital and public health care system in Cook County. It did get rebuilt. It had a network of clinics. It's a beautiful place. It's gorgeous. And I sat on the board of it for 4 years. But along the way, I became an epidemiologist. I became interested in the true cause of disease and stuff. And so I have this, and I call it the death gap, this inequality, the fact that there's a death gap in this country between rich and poor in this country. So these are 3 numbers I think are important to note. 136, life expectancy rank of the United States and the world. In a good year, we're a little bit ahead of Slovenia, and on a bad year, a little bit behind Slovenia. But we're not where you would think we would be given our investment in healthcare in this country. And there's a big discussion about that. Healthcare is about 20%. There's other things that determine life expectancy, but I'm going to focus on the healthcare part of this. 30 is the life expectancy gap in the United States between the lowest mortality community and the highest mortality community. In Chicago, you can walk 6 or 7 blocks and lose 20 years in life expectancy. There's a gap in this country. And if you look at Great Britain, the gap in Great Britain between the poorest community and the highest community is about 13 years. It's a gap. There's no question there are other things that contribute to the gap, but our healthcare system is somehow doing, and 50 million uninsured in this country. So these 3 numbers contribute to this. So this is some of my work and my wife's work on breast cancer in Chicago, just to show you what's happened over time. So you see there are 2 graphs here. Now this is black and white because it's easier to get race than it is to get income. But this is really a story about income disparity and inequality playing out for one disease. So I take the death gap, I'm taking one disease. So what happened, I started this breast cancer screening program in about 1984. In those days, there was no mortality gap between black and white women in Chicago, or between poor and rich by extrapolation, because no one was getting screened. There was really no adjuvant chemotherapy, and the treatment for breast cancer was pretty much the same. But what happened is we introduced these modalities, screening, borderline intervention, but it works, and then adjuvant chemotherapy. And you can see what happened is the white mortality rates went down nicely. We're not saying we've solved the problem of breast cancer for white women in this country, but it went down as you would expect, and the black rate didn't move at all. So this was a study that we published in 2006, and when we were getting involved with how do we actually fix some of these inequalities. And then what do you think the response was when this came out, the reason for this gap? The reason for this gap. Any ideas? Pardon? Education, access, and biology. Biology. And so here's what we know about breast cancer in poor women, black women in particular. Tends to be larger, more undifferentiated, less likely to be estrogen receptor positive, things that have poor prognostic factors. And so a lot of people attribute this to access and biology. So then we did the gap. We looked at the gap in 3 different cities. Now this is done in 25 different cities, and it holds. In some cities, there's no gap. In some places, the gaps are very big. But you can see the gap between black and white in Chicago, US, and New York City. So one is there's a gap, and it's national. But you also have to ask if it's genes, if it's biology, what happens to your genes when you cross the Allegheny Mountains? So this is something about locations. So then we did a map, and this is probably not so different than rural. I'm talking about urban stuff, but this is rural. So we just mapped the highest mortality communities from breast cancer in Chicago. There are 24 of them. You can see there in green are African Americans, and blue is a white community. That has nothing to do with race. And then we overlaid that map with the hospitals that have accredited cancer programs by the American College of Surgeons. It's a quality measure. You come and you get inspected. And what do you see? That why have these women moved into communities that don't have accredited healthcare institutions? You see, this has nothing really to do with race, because it happens if you're geographically isolated. It has to do with these are communities that lost institutions. And why did they lose institutions? Because they couldn't afford to be there. And so the institutions that were in the wealthier communities or could survive because of their location did survive and thrive. And you end up with these sort of geographic inequalities. Urban America is no different than rural America. These things occur. We have a lumpy, bumpy health system, and where you live has a lot to say with how long you're going to live. So I just said, I'm going to see what's going on in Salt Lake. This is from the Salt Lake City Tribune, and from March 5th, and this is from University of Utah. And I like the language here is important. Poor uninsured women prone to late-stage breast cancer, says University of Utah study. Risk of a late diagnosis 80% higher in the uninsured. Well, what does he mean prone to it? Do you know what I mean? Prone means you have a predisposition to. Makes it seem as if it resides within the women, when it actually perhaps resides within the system. And my wife and I did a study of black and white women in Chicago who got their breast cancer diagnosed after a negative screening mammogram at either Rush or Northwestern. And there was very little difference in those two groups. It was the kind of care you get makes a difference. And again, I'm sure in Utah, some of the things are very similar. All right, time to pull your cell phones out. This is the poll. There's and a little bit of caution about surveys. This is a survey that was recently done by chicken manufacturers. Now, being from Chicago, you can see, this is Chicago doctors, that the rats was thought to taste better than the Kentucky Fried Chicken. But okay, we're going to try this little poll. I got my technical crew over here. But I'm going to ask you, these are now questions. The first question is a test question, but here's how you do. You pull out your cell phone. You go to your messages or where you do text. And when you get to the question, you're going to put in 37607. That gets you access to the poll. And then the answers to the poll, oddly, say OSMS, and it'll be followed by numbers. So I'm going to give you a chance of a test poll with the first one. So this is now, you get to rank my talk so far. So you text 37607. And then you can put in whether it's OSMS 001, OSMS 002, or OSMS 003. Isn't it amazing what we can do in Ogden, Utah? It's just See, by now in a talk, everyone's pulled out their phones anyway. So I might as well have you be doing something useful here, And the nice thing of polls, if you design the questions the right way, you can get whatever answers you want. We have the capability of doing up to 250 answers. You can vote more than once. But I think when we get to about 60, we'll stop and we'll go to the next one. Well, it looks like amazing and tastes like chicken are the two highest votes here. So we're going to the next one. So this is now, the U.S. healthcare system works well, only minor changes are needed. If there are anyone here who teaches residents, you can do this really easily at any teaching session and prepare your talk the night before. We'll give a few more minutes to see the U.S. healthcare system works well, only minor changes are needed. Well, it seems to be holding strong at 94% thinking false. No, 90, here we got a few more. Come on, optimists. We need a few optimists in here. I'll say this while you're voting. You know, being a doctor is one of the greatest honor in the whole world, to be there with patients. You think why we went into it, what we do, the ability to come together in community like this around learning. It's a spectacular profession, and yet, look at the system we work in and how we vote. Okay, we're going to go to the next question. My patients often have difficulty with health care out-of-pocket costs. And this is true or false again. And you can vote for someone else at the table who doesn't have one of these capabilities, because I realize this is, the fact that we're even doing this is quite amazing. All right, I think we got a good feel for this one. We'll go to the next question. So people are saying true. This seems to be, it looks like it's maybe 80-20. Okay, 80-20 here. Insurance restrictions to patients for medications or treatments pose major time concerns for me and other doctors. Now, nurse practitioners can vote too, and PAs should vote as well. So even if you're from like Manila, Utah, I'm looking for a vote from you, man, okay? Yeah. See, the nice thing about this is we really, I don't know what people believe or think, and before I have to impose my views on you, at least I get your views and such. Okay, again, it looks to be about 80-20. And let's go to the last one. I'm very satisfied with the practice of medicine. We all went to it really enthusiastic, with great ideals. And where are we now? Oh, this is a pretty predictable crowd. I say 80-20 on any kind. Oh, look at this. Look at this. That's great. That's great. That's a real vote there. I bet you would all say you love being a doctor, but you hate, if you don't like it, you're not sure you like the way we practice medicine. And those are two different questions. But let's just agree we're 50-50. And let's just do this one. My patients who are on Medicare like their Medicare. I'm not asking if doctors like Medicare. Pretty cool technology, isn't it? Isn't it cool? It's called Poll Everywhere. You just go Poll Everywhere. It's so easy to use. And you can see it does a lecture for you. But okay, let's just call this, it's a little hard because I did this with a different scale. Let's say 60-40. Okay. Now, the questions you answered, except for the last one, were part of an international survey done in 2012 by the Commonwealth Fund of doctors across the world. And I'm going to just go through with you how American doctors compare to other doctors around the world. And I highlighted, for the sake of this, Canada, Germany, UK, and US, because we'd all agree we're not like Sweden at all. But just to say, so along a series of questions, doctors' perception, their patients often have difficult paying, out-of-pocket costs, and you can see the US, 60%. Difficulty getting diagnostic testing, a little bit more in Canada. Long waits to see a specialist. Look at UK here. Canada and Germany more. Physician views of the healthcare system. System works well, only minor change is needed. We were 80-20, remember on this? So look at this, of all the doctors in the world, you can say there are not many doctors that think their systems are great. The Norwegians in the Netherlands, they feel better, but look where the United States doctors are surveyed in this. You know, we would all agree, I think, fiercely that our system does not work well. And today, I think we got similar votes here. Insurance restrictions or treatment for patients pose major time concerns for doctors. Look where US doctors are here compared to all the other doctors surveyed in the world, much higher. Physician satisfaction medicine. Look where the rest of the world ends, and look where we ended here, even in this room. So despite these other systems, the Germans are less happy than we are, and most of our docs are satisfied here. But you can see it's lower than some of these other countries. All right, part one done, part two done. We're heading through the home stretch now, part three. Triple aim of health reform. It's the goal here, right? Better care, patient-centered, safe, effective, timely, access, better care, better experience, better population health, life expectancy. It's got to do something to the health of the population, and lower cost. That's the triple aim of healthcare reform. That's supposedly what we're trying to achieve here. So first, there's so much money in this system, it's ungodly. You know, Russia, CMO, I can find waste wherever you look. It's easy to get waste out of a system. There's so much of it. So this is U.S. health economy, that's trillion dollars. I meant to change that, $1 trillion, not $1 billion. And if you ranked it as a world economy, it would be fifth in the world, above croissants, above eclairs, above Bordeaux wine, all of France's economy, U.S. healthcare. And if you look at the federal spending for healthcare, it's not quite $1 trillion. It would be the 16th biggest economy in the world. We got plenty of money in this system. It's just how's it being spent? So we spend more, but we live less. And this is actually the rise in cost of healthcare costs in the United States compared to the rest of the world. We were all bunched together at one point in time. And in this period of time, we saw uninsured going from 25 million to 50 million. And we saw the rise in our costs at the same time. So as we spent more people were uninsured. It's almost like a system designed exactly to get you these results. This is another one I like. And as our costs went up and our uninsured went up, administrators went up. So maybe if we eliminated administrators, our costs would go down. But I think these are ecological associations. They're not necessarily cause and effect, but they're all occurring at the same time within the same system. So I'm going to talk about the Affordable Care Act. To me, I come to it from a point of view of, is it equal? Is it equal? There are big cost reasons to fix it. So here's what it says. Better care. Does the Affordable Care achieve it? So if you like your employer-based health insurance, you can keep it. But if you don't like it, you have to keep it. You don't really have to keep it. Let's say your employer-based health care insurance is being dumbed down every year. and such, it's hard to get out of it, and it's hard to find something elsewhere that's going to be better than the worst package an employer might give. And I know, being a big employer in Chicago, the healthcare costs are killing us as an organization. Then you're going to have marketplaces, which we'll talk about, and then Medicaid expansion. And I want to talk to you about these all separately. First of all, this idea of better care. There have been plenty of trials. So does getting health care, is that a good thing or a bad thing? Because we can have all kinds of beliefs. But there have actually been trials on this, or trials and studies. So the Rand health insurance experiment, New England Journal of Medicine, 1980s, looked and said, what happened if you took people without insurance, you gave something full ride versus a full ride with copays. And what you found, if you made poor people copay, they stopped getting essential services. So randomized controlled trial. I'm going to show you some more data on it. In 2010, health insurance and mortality, uninsured have 40% higher mortality than insured, 45,000 deaths. And there's this great experiment in Oregon where they gave 10,000 people Medicaid in a lottery, and they watched what happened, and they gave 10,000 without, and they watched what happened. And they have better outcomes, happier, less bankruptcies, better self-reported health, et cetera, just by getting that Medicaid card. This is a study in the New England Journal of Medicine that looked at what if you make Medicare recipients copay. And there's two things that happen, whether you're wealthy or not, that if you make them copay, they're less likely to go outpatient visits and more likely to be hospitalized and more inpatient days. It's studies. This is data. Joe, we have a belief in this country that we should pay, because if you pay your way, it's a good thing. It's a moral issue, and I'm not saying it's not good to pay. I'm saying the evidence is if you take very poor people and even people on fixed incomes, and you say we raise your copays or we do those things, that the evidence suggests that you're more likely to go get expensive services and less likely to get the least expensive services. And we have from randomized controlled trials and others, and so that's data on it. So here's the marketplaces. Each one has a copay part of it. So there's platinum, gold, you can see the copays on top, silver, and bronze. Now think about this. You're a low-end worker. You now have a mandate. It's not a right, it's a mandate. You must go out and buy it. And what are you going to buy? Your kids, 27-year-old, right? Out of college, not working. What are you going to buy? Bronze. And what do we know about copays in poor people? The evidence is you're going to have bronze, you have a card, but you're likely not going to use it when you need it in the right ways. Is it better than nothing? Yeah, it's better than nothing, because being uninsured is pretty horrible. But having this card, the literature is going to suggest we're not going to use it. Actually, the model programs in every state that's doing marketplaces is silver, 30% copay. And if you think what's killing Americans right now, the middle class, is copays. The co-insurance, copays, and everything. It's not not even those with insurance are struggling with copays, because most of the country is not rich. Great study. No, Medicaid. Medicaid, we saw if you gave someone in Oregon Medicaid, they were happier. But Medicaid is like Confederate money. You can have a Medicaid card, but you can't spend it everywhere. You can hardly spend it anywhere. Medicaid's a terrible system, I think. Again, is it better than nothing? Yes. Presumptive eligibility for pregnant women is a good thing, but it's like Confederate money. You can't spend it. Study in Chicago, secret shoppers. I have Brenda. I'm going to take one condition. Brenda's my little baby girl. Don't do adults, because no one likes adults, but babies, everyone loves children, right? So I have Brenda. She's a little baby girl, and she has a broken arm. And we call up orthopedic offices. So that's condition number 2 there. And we say, my baby Brenda has a broken arm. Can I get them in to see you? These were random, all the orthopedic offices in Chicago, academic, private, others. And if you said, my Brenda has private insurance, 98% got in to see the orthopedic surgeon. But if you said, my baby Brenda with her broken arm has Medicaid, 20% get in. Same condition, same phone call. And where do you think they told the mother where to take Brenda? County, Cook County. So every story, every road begins and ends at Cook County in this talk. But this is data. This is a study, New England Journal of Medicine last year. Okay, you ask patients, you survey patients. about a series of problems, access problems, bill problems, how much out of pocket you've spent. Insurance is excellence, my quality is excellence. People who hold that Medicare card are more likely than people with insurance or uninsured to say, it's pretty good. It's not perfect, it's pretty good. All right, now I'm going to do this. Any orthopedic surgeons in the room? Okay, because this is about primate behavior. We're all primates. We're not that far from chimpanzees, but I'm saying we all behave in certain ways. And I'm talking about this inequality thing. What happens to us when we're given different incentives? And I think this little study shows you. And imagine now you're dealing with an orthopedic surgeon, and a patient has Medicaid, and a patient has Blue Cross Blue Shield. Okay, can we run this, please?
That I want to mention to you is our fairness study. And so this became a very famous study, and there's now many more, because after we did this about 10 years ago, it became very well known. And we did that originally with capuchin monkeys, and I'm going to show you the first experiment that we did. It has now been done with dogs, and with birds, and with chimpanzees. With Sarah Blossom, we started out with capuchin monkeys. So what we did is we put two capuchin monkeys side by side. Again, these animals, they live in a group. They know each other. We take them out of the group, put them in a test chamber. And there's a very simple task that they need to do. And if you give both of them cucumber for the task, the two monkeys side by side, they're perfectly willing to do this 25 times in a row. So cucumber, even though it's really only water in my opinion, but cucumber is perfectly fine for them. Now if you give the barley grapes, the food preferences of my capuchin monkeys correspond exactly with the prices in the supermarket. And so, if you give them grapes, it's a far better food, then you create inequity between them. So that's the experiment we did. Recently, we videotaped it with new monkeys who never done the task, thinking that maybe it would have a stronger reaction, and that turned out to be right. The one on the left is the monkey who gets cucumber. The one on the right is the one who gets grapes. The one who gets cucumber, note that the first piece of cucumber is perfectly fine. She eats. Then she sees the other one getting grape, and you will see what happens. So she gives a rock to us, that's the task. And we give her a piece of cucumber, and she eats it. The other one needs to give a rock to us. And that's what she does. And she gets a grape. And she eats it. The other one sees that. She gives a rock to us now, gets again cucumber. She tests her rock now against the wall. She needs to give it to us. And she gets cucumber again. So this is basically the Wall Street protest that you see here.
All right. You know, this debate on health reform, it's confusing, right? I mean, there's beliefs, there's data, and then there's the politics of all of this. There's the noise around it. That actually experiment, I said there was orthopedic surgeons. You can actually do this with general surgeons, family medicine docs, and internists and get the same result. The fact is, you think about this for a second on this concept, because I see this at Rush. Number one, at all three institutions I worked, the number one topic was money, always money. And the unequal distribution of money isn't right. It creates these inequities, and now you're within your own little box. And I know I can't blame anyone when you're raising a family and you're trying to do something, and you can see something, and you can get $18 in Illinois for a Medicaid visit, maybe $70 for a Medicare visit, or $250 for a Blue Cross visit. That why, in the face of those incentives, wouldn't you behave in a certain way? And that altruistic beliefs isn't a system. Doesn't create a system. In the end, It's one thing that we have income inequality in this country, and we have that, and the gaps are getting bigger between CEOs and the frontline workers. But the idea that this stuff can lead to death through these unequal systems, to me, is kind of an unacceptable concept. But it was a confusing debate. So this is, oh, there's one before this I'd like to show. Can I go back? Oh, this is my favorite one. No pubic option. I am against pubic options. Anyway, there's a bunch of great, there's nothing like political discourse in this country. Man, it's like better than Comedy Central sometimes. But it was a confusing debate, no pubic option. And this one, don't steal from my Medicare to support socialized medicine. Wait a second, Medicare is socialized medicine. We have in this country every kind of health system that the world has. The VA, the military, the public hospitals. So across the street from County Hospital is a park. It's called Pasture Park. It's where the helicopters run. It's right between County and Rush. And on this statue has a plaque on the back. There's Louis Pasteur, and there's this plaque. And it says, one doesn't ask of one who suffers, what is your country and what is your religion? One merely says, or your insurance, one merely says, this is enough for me, you belong to me, and I shall help you. And I think whether you're a PA in Manila and someone comes to your door and they need help, or you're a general surgeon here in Ogden, someone needs your help, as a doctor, we do it. That's what we do. And the rest is the discourse around it. That's why I became a doctor. So I'm going to end here, take questions. So I believe the guaranteed right to health care is a moral, not a mandate, is the moral question of our time, and we haven't resolved that as a country. And when we do, this will all be easier. That the cost of our health care system, the way that it's set up right now, is unsustainable. And the only way to an Affordable Care Act, one we're enacting right now, will perpetuate these separate and unequal cares because of differential incentives and all sorts of things. It's just human behavior. It's just the way it is. And only with something that's a single payer type, improved Medicare. I call it Blue Cross for all because we're paying certainly enough money in the system for everyone to get Blue Cross. But only with a system like that can we achieve everything we want to do. And I like to say, in the words of Winston Churchill, being sort of split between England and the United States, he said this about Americans. Americans always do the right thing after exhausting every possibility. And anyway, thank you, and I'll take questions. Yes. State by state. I think states have to figure this out, actually. And I think that one would do, so first of all, we're paying for health care for the uninsured right now through emergency rooms, and we're putting people in nursing homes. There's things that happen to people. We wait till people get really sick, and then we take care of them. So the fact of the matter is we're paying for these costs now. I would do it state by state. That's how Canada did it. And there's lots of different ways to do it. Germany's a little bit different, used insurance companies. Right now, insurance companies in most states are the Medicare administrators. So I would use insurance companies, but if you look at the waste in our system, there's a certain amount of it, probably about a third of it, that's just administrative waste. Billing things, the billers. We have as many billers at Rush, finance, as we do doctors. And I think most places would look at that. What you need to collect a bill in this world is crazy. And then another 25% or so is over-testing. So we have to change the way we practice. I'd like to see doctors more in control of this. I think population health really begins with doctors managing the health, because doctors manage the health of the patients. It's not hospitals or institutions and such. But I would start local. I think this would be local. And we need some experience with it in this country. I think our current system is going to fall. So if you notice the rate, we said, oh, we're doing really good. Healthcare, the rise in healthcare expenses in this country was only like 3.9%. Well, that's wonderful. But rise in wages and inflation is like 1.5% to 2%. So the rise in healthcare costs or double that of the rise, even at a low rate, it's double of that of wages. So I think it's got to be statewide because I think you need everybody in. I think what happens in this sort of healthcare reform is expecting the 27 to 35-year-olds who aren't sick to go out and buy insurance now. And these systems only work where everybody's in them because you need a big enough pool. That can only be done at the state level or the national level.
I've got a question. I just wanted to refer to your slide where the countries were fairly equal back in 1980, and then there was a big split thereafter.
Yes.
When I was growing up, many of my relatives were doctors, and they were being paid in grapes, not cucumbers, and I don't remember any of them complaining about where's the money going? It certainly hasn't been going into physician
No,
pay.
I think this is it. I think the enemy here, if you want to say, is the insurance companies. I think a lot of this is, so where's the money going, you're asking? So, and actually, you know what happened? Life expectancy in Canada and the United States weren't that different. And Canada's gained years on us, even since they went to the National Health Program. Well, look at the way it's run now. I mean, it's just crazy. You've got all these different, I want to say, like in Illinois, we have 1,300 insurance companies. And I think there's 13,000 in the country. There are all these different payers. Everyone, even at the county hospital, there's this kind of Medicaid managed care and this one and this one. And it's all waste. None of it goes. So what you and I do, I only do it part-time because I'm an administrator part of the time, part of that blue curve. But when we see patients, it's very efficient. Do you know what I mean? It's us, it's the patient. Maybe you have a medical assistant who gets the patient in the room. Some people just bring the patients in themselves. Very, very efficient system. But when you layer on the billing and the waste and the arguments over enrollment and stuff, these are all costs that don't actually get to the sharp end of delivery. So I think what we've done is layer all these things on. And I do think care has changed over the last 25 years, where what could be done singly now gets done much more in teams. We need the cardiologist and the gastroenterologist to deliver care. Yes, question?
The general consensus, I think, of doctors is that we care for people. But the problem we feel also is perhaps patients don't take care of themselves. So how do we, as a system, incentivize people to take care of themselves and not to use an ICU in their last 10 days of life?
Yeah, that's a great question. Well, Americans in America, the healthcare system will always be more expensive than the rest of the world because we do have these beliefs, and or somewhat of a belief in our own immortality. It's very hard to overcome that. And if you look at where the costs are spent, 10% of the population accounts for 63% of the costs. So it's a huge amount of cost dealt with at end of life. So a couple things I think have to change, but beyond the payment, beyond sort of how the system is fairly distributes pays, we actually have to change the way it's delivered, I think. So fee-for-service incentive is a bad system in terms of the incentive versus managing a population and shared savings. We do have to look at things like end-of-life care. A few years ago, Rush was on the top 10 list, and everyone was celebrating. Oh, we're on the top 10. Yes, I said, yeah, top 10 for end-of-life costs in the United States. And what we initiated was, mandatory nurse practitioner palliative care rounds in our ICUs. So the discussions began to occur that needed to happen. So there's a lot of things problematic with our system that go beyond payment, and you mentioned one of them. But I do think we have to change our delivery model, actually, and to get the population health. And I think doctors are the best to do it, doctors in groups. Now most of us are being bought up. So there's a reason why hospitals are buying up doctors, nurse practitioners, and the like, PAs. It's because they want to be able to control their destiny. And in the end, it's doctors who provide the care, and nurse practitioners. It's not the hospital administrators don't provide care. Buildings don't provide care. It's the doctors and nurse practitioners. I do think in the end, we're the best to do this, but we've let it slip away too, unfortunately.
Two questions. what percentage of the healthcare dollar is for defensive medicine? And the other one is, why is there such a discrepancy of primary care hand-holding services versus surgical procedures?
The first question is a little hard to answer, but some people think it could be, some people think it's a small percentage of, so this Institute of Medicine did the study and they looked at where the excess costs were, and that's where the third and the 27%. So that 27% is excess testing. Not all of that is defensive medicine. I think many of us would probably agree, the gray hairs in the room, that we've gone away from clinical diagnosis and way more into testing as the first response, and that's how we're training doctors. So I think defensive medicine turns out is about 3%. I do think we need tort reform as well as a real payment reform, but I think it probably, when people have looked at it, is a small percentage. Now, I didn't quite get the point of your second question.
Well, I mean, you have a neurologist who spends all night by a stroke victim and has as many hours and time in, and then you have an orthopedic who does one procedure and gets 3 times more money.
I'll tell you this, is my chief of orthopedics at Rush is the president of the American College of Orthopedic Surgeons. You should go to one of their meetings. Boy, they're really anti this. But I actually had a conversation with him about this stuff. So, this is all duked out nationally at so the payments for doctors by Medicare, which actually set the payments for everywhere in the country, occurs nationally, and the specialty societies get engaged. And I will guarantee you, the primary care, the general surgeons, the general medicine docs have not been as effective at the table with this as the specialty docs, and so that's why you have some of these inequities. It's going to change. I asked the same right before he got inaugurated, Josh Jacobs. I said, Josh, can you guys make a living if you just got Medicare? They operate the way they do. Yeah, we could make a living. It wouldn't be as good a living as we make. These guys actually make a living in Chicago off of workman's comp, which is federal, which is government dollars in the end, which are highly paid government dollars. But I do think that some of this payment, how people get paid is a national thing, and our specialty groups have to be at the table. That is changing. But the problem we have in this country is an aging primary care and general surgery workforce. Most primary care physicians are within, half of the primary care physicians are within 6 years of retirement. I think the recession kicked a few of us in there a few years longer. But I think the problem is we're not going to have enough primary care physicians. And that's really, I think, where you're going to bend some of the costs in the system. Yes, sir?
You mentioned that you felt the real culprit is the insurance companies. It seems to me that the other potential real culprit is political, and that may actually be part of the same issue. But in your experience at Cook County, you interacted with politicians a great deal. Do you have an answer to the political problems?
Oh no, listen. These are inherently, what I learned that first year in medical school, that healthcare was not just about altruism, but it was about politics and money, and that you have to decide where you land on this thing, because I think we have to be politically engaged. I think doctors organize is huge, medical societies and other things. Our problem is oftentimes we've been organized on the wrong side of some of these issues and such. I think I want to be respectful of the time, so a couple more questions. Okay.
One more question over here.
So the point is, we must be engaged. I don't care if you agree with me or don't agree with me, but I tell you that what we would all agree with, doctors need to be politically engaged with these ideas, because there is one lobbyist for every member of Congress from the insurance companies, and they're there all the time. They spend billions of dollars on this. They wrote the bill. That's who wrote the bill. And we got the bill that saves them and keeps them exactly where they are, and forces all of us into arrangements, perhaps, where we have no leverage. Question, sir.
Okay, I've been in a couple of countries like Germany.
I'm sorry, I didn't see this list. Can you excuse me? I'm left-handed, and I've been looking over to my left, and I have a whole group of people over here. If you don't mind just waiting, sir.
It's the blind side over here.
Yes.
Yeah, I trained at Boston City in the 1980s, and we had the identical issues, and it was great to hear those stories. I still remember ordering an x-ray and then learning that as the intern, I had to push the patient from Medical 7 down through the tunnels up to the x-ray department, and then they'd call me when he was done, and I'd pick him up and bring him back. Those were great days. I'm glad they're gone. But my question to you is this. You mentioned about the, I assume the single-payer option is what you're advocating. Clinton tried something similar, and it boomeranged back, largely because of the dollars that went into the health industry. If you remember the Harry and Louise ads. And I think that got taken off the table almost immediately during the ACA discussions. And it's such a powerful lobby. Any attempt, and certainly I'm from Massachusetts, and that any attempt at getting a single payer, although I know many people wouldn't share that ideal here, but any attempt at getting single payer, like Medicare expansion, was shot down almost at the outset. And the spending within Massachusetts, when this was being discussed originally, was something like 5 or 8 to 1 against it. So I just wonder, when you talk about the solution coming from the states, I don't know any state in this country that's going to be immune from those political pressures and from the monies that go to this incredibly powerful lobby that has a lot of Congress in its pockets. I'm not sure what your answer to that is.
Well, you know, well, thanks for that shout out to Boston City, but I think we all know what I'm talking about. Listen, I'm an inveterate optimist, and I think part of the lesson of going to Cook County Hospital was, you know, you had to really fight for your patients, and you had to fight to get things done. And this is one of those fights, and yeah, the opposition is formidable. Does anyone remember what senator blocked the public option in healthcare reform? I'll give you a hint. From the state of Connecticut.
Dodd?
What?
Dodd?
No, who is Lieberman?
Oh, it was Lieberman. Yeah.
Lieberman blocked it. In state of Connecticut, what's the capital of Connecticut? Hartford. And what's in Hartford?
Insurance. Democrat,
right? The special interests are embedded. Yeah. You know, I think this is the cost problem has not disappeared. The idea that at some point in time, as an employee, your health insurance costs could be at some point mathematically higher than your wages is a likely phenomenon. We're going to be back to the drawing board. There's like 27 industrialized countries have done this, capitalist countries have done this, because they've realized there's no ideal system, but they've realized it's better. I don't know how we oppose it, but I'm inspired by like other things in this country. You know, when women decided, when Susan B. Anthony in 1840s came out and said, hey guys, women should have the right to vote, you know, they were not enthusiastic about that idea. And it took from 1840 to 1920 to get that. So it's probably a long haul. I was at a double AMC meeting, deans of medical schools, and when people were talking about health reform, people got up from the audience and said, listen, they started talking, what about single payer? What about these other options? So hopefully, you know, the logic and the cost of it will get us there someday. But I'm an optimist. And that's why I came to Ogden, Utah. You know, my God, if Ogden, Utah wants to hear me, maybe there's hope everywhere. I get invited. I'm just saying is that you would think, you know, we all practice in these settings and we don't think of the macro and what would be better. And in the end, we'll come to the right idea. It just takes a long time, but we have to have these dialogues and discussions with each other, you know, even if we don't agree, because I don't know if it'll be totally single pay or something. It's got to be better than what we're getting, though. Sir, I'll get you now.
Okay, I've just not too long ago been to a couple of countries where they have one pay. Take as an example Russia. Taken as an example, I've been to China. I've been to a lot of these countries that have one pay, or the government pays. I'm not really sure, and I've been to America where they don't have one pay. Look at the consequences between those countries. So once they get something for nothing, there's no object in bettering yourselves. If they say I'll pay for everything, I'll vote for everything. If I'll pay everything I've got, I'll vote for that.
Yeah.
And I really don't want it. I really appreciate the fact that the competition is here in the United States, and the competition is making us better for it. We get rid of all of competition, We're just like those one-payer countries that are having a difficult time.
Yeah. Yeah, I think, listen, there's a big suspicion of government in this country, and much of it well-deserved, and that could probably get in the way of it. You know, I do think, though, there's some recent countries that have turned to this. Taiwan recently, Switzerland. You know, they've all done it for a reason. It's not a bad idea to sort of study that. And I think the key is you want a private system, so there is competition. You don't want to eliminate competition here, because we have to compete over better care. Do you know what I mean? And that's what I think, and people have to have choice. Anyway, thank you, everyone, for having me.
Okay, thank you.
Thank you so much. Thank you so much, Charles.
You could go out and sign some books?
Yeah, yeah.
Okay, good. I'll see you. So he'll be out in the